Hi there, my highly valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I humbly urge you to sit back and spare me part of your very precious time as I share with you some tips which you may find useful in your line of duty. Welcome. Our first question reads, JWW, a 70-year-old male patient, presents to your anticoagulation clinic with non-valvular atrial fibrillation. He has a past medical history of coronary artery disease, type 2 diabetes mellitus, hypertension and hyperlipidemia. Currently, he takes 20 milligrams of lisinopril once daily, 12.5 milligrams of carvedilol twice daily, 1,000 milligrams of metformin after breakfast and after dinner, and 20 milligrams of rosuvastatin at bedtime, alongside 5 milligrams of warfarin once daily, and routinely he takes 200 milligrams of naproxen when in pain. He is a non-smoker who drinks approximately 10 bottles of beer weekly. Some of his vitals include a systolic blood pressure of 138, diastolic 80 millimeters of mercury, and he has a heart rate of 88. He is currently on warfarin therapy and has a time in therapeutic range, which we abbreviate as TTR, of 55%. The lab results are within normal limits, with an exception of serum creatinine, which stands at 1.6 milligrams per deciliter. So my task to you is to compute JWW's CHAD-2 VASC score and his Hasbled score. Is it a CHAD-2 VASC score of 2 and a Hasbled score of 5, or is it a CHAD-2 VASC score of 3 and a Hasbled score of 4? Is it a CHAD-2 VASC score of 4 and a Hasbled score of 3? Or is it a CHAD-2 VASC score of 3 and a Hasbled score of 6? I'll give you 10 seconds to compute the correct value. B is the correct answer. The CHAD-2 VASC 2 score is 3, while the Hasbled score is 4. Now, we know that JWW has non-valvular atrial fibrillation. He has 3 risk factors for stroke, according to the CHAD-2 VASC 2 score. He earns 1 point for hypertension, 1 point for type 2 diabetes mellitus, 1 point for age between 65 and 74 years old, and JWW's risk for major bleeding based on the Hasbled score include 1 point for labial INR based on a TTR of less than 60%. Remember, we were told it falls at 55%. He also earns 1 point for age above 65, and 1 more point for medication usage that predisposes him to bleeding. Remember, he takes naproxen, and NSAID, PRN. He also earns 1 point for alcohol usage above 8 drinks per week. Now, when calculating the Haspled score, a patient's systolic blood pressure needs to be above the 150 millimeters of mercury mark to receive 1 point for hypertension. Unfortunately, our patient does not meet that requirement, and they also need to receive 1 point for renal disease if the serum creatinine exceeds the 2.26 milligrams per deciliter mark. Again, our patient does not meet that requirement, or they should be undergoing dialysis, or they should have had prior kidney transplant and a point for those kidney issues. Now, I would just like to emphasize the fact that the CHADS 2/2 score is a validated risk stratification tool that is only applicable to assess risk of stroke in patients with non-valvular atrial fibrillation, and it's usually expressed in number of events per 1,000 persons per year without being on anticoagulation. Now, it isn't applicable for calculating thrombosis risk for patients with DVT or with PE. The Haspled score, on the other hand, has a 9-point scale to assess the risk of major bleeding with warfarin use in patients with non-valvular atrial fibrillation, and Haspled score of 3 or higher is usually considered increased risk of bleeding. So our patient who scored 4 has an increased risk of bleeding, just by the way. Let's move to the next slide, please. A medical resident on call at the anticoagulation clinic contacts you for your recommendation on the best anticoagulation therapy for a patient he has just diagnosed with unprovoked proximal DVT. The male patient is a 58-year-old man, and he has a past medical history of coronary artery disease, hyperlipidemia, and type 2 diabetes mellitus. The patient takes 1 to 2 beers weekly, and he smokes 2 packs of cigarettes on a daily basis. This patient uses a pill organizer. His renal and liver functions are within normal limits. So my question to you is, which of the recommendations below should be or would be the most appropriate for this particular patient? So would you opt to manage his case with 150 milligrams of dabigatran taken orally twice daily? Or would you settle for 10 milligrams of apixaban taken orally twice a day for a week, followed by half that dose of 5 mg twice daily for a prolonged duration? Or would you settle for 20 milligrams of rivaroxaban taken orally once a day? Or would you settle for enoxaparin bridging therapy? That is enoxaparin until warfarin is dose adjusted to an INR value of between 2 and 3. I'll give you 10 seconds to choose the correct answer. So B is the correct answer. I would opt for 10 milligrams of apixaban twice daily for a week, followed by 5 milligrams of apixaban twice daily. It is the appropriate treatment strategy for an acute DVT. Now, monotherapy can be initiated with apixaban at a higher dose, which is 10 in our case, twice daily for 7 days, followed by 5 milligrams twice daily for the appropriate duration. Now, according to the CHEST guidelines, on antithrombotic therapy for VTE. Direct oral anticoagulants, what we abbreviate as the DOACs, are recommended over vitamin K antagonists such as warfarin for VTE treatment without an associated cancer diagnosis. Now, if you opt to use dabigatran, it should be preceded by a low molecular weight heparin for 5 to 10 days before initiating the dabigatran for appropriate duration. Additionally, dabigatran needs to be stored in its original pack. Remember, a patient uses a pill organizer. He'll compromise the shelf life of dabigatran, so I would not recommend it in his case. Now, the rivaroxaban dose in C is wrong. The correct rivaroxaban dose would be 15 milligrams taken orally twice daily with food for 21 days, followed by 20 milligrams taken orally once daily with food. Now, according to the CHEST guidelines for VTE without an associated cancer diagnosis, all DOACs, direct oral anticoagulants, such as dabigatran, rivaroxaban, apixaban, and edoxaban, are recommended over vitamin K antagonist therapy. Now, on the other hand, the vitamin K antagonist therapy is recommended over low molecular weight heparins. So the superiority is in that order. Now, for VTE associated with cancer, the low molecular weight heparin is recommended over vitamin K antagonist therapy. I would just like to add that warfarin therapy may be the appropriate option in cases of poor renal dysfunction, or if the patient can't afford a DOAC. Now, in these situations, enoxaparin therapy should be initiated with warfarin and overlapped until a therapeutic INR of 2 to 3 is achieved. Then the enoxaparin can be discontinued, and the warfarin should be continued for an appropriate duration according to the physician managing the patient. Let's move to the next slide, please. The question reads, JBO, a 65-year-old male patient, is hospitalized in your facility after undergoing a mechanical mitral valve replacement. He is recovering well. Now, he has a past medical history of hyperlipidemia, gout, and erectile dysfunction. His EKG shows normal sinus rhythm, and his lab values are unremarkable. He is currently receiving enoxaparin subcutaneously. He will be discharged on oral anticoagulant therapy. So my question to you is, which of the management strategies listed below would best suit Mr. JBO? Would you choose to treat him with apixaban at a dose of 5 milligrams orally twice a day? Or would you opt to continue enoxaparin until warfarin is dose adjusted to an INR of 2.5 to 3.5 and additionally administer aspirin at a dose of 81 milligrams orally once daily? Or would you choose to send him home on aspirin monotherapy at a dose of 81 milligrams orally once daily? Or do you think oral anticoagulation therapy isn't necessary since his EKG shows normal sinus rhythm? I'll give you 10 seconds to choose the correct answer. So I would send this patient home on continuation of enoxaparin until the warfarin is dose adjusted to an INR of 2.5 to 3.5, and additionally I would prescribe aspirin at a dose of 81 milligrams orally once daily. Now B, in my opinion, is the correct answer, because warfarin is an appropriate anticoagulant for use in patients with mechanical mitral valve replacement, where there is a high risk of thromboembolism. Actually, warfarin should be targeted in such patients to the INR range of 2.5 to 3.5, and additionally aspirin should be co-administered at a dose of 81 milligrams orally once daily. Now, aspirin monotherapy in alternative C wouldn't provide adequate protection for stroke in the setting of mechanical mitral valve replacement. It is appropriate, however, after an aortic bioprosthetic heart valve replacement due to the lower risk of thromboembolism in such cases than with mechanical heart valves. Now, DOACs such as apixaban aren't approved for stroke prevention in the setting of mechanical heart valve replacement. Now, the risk of thromboembolism can be 20-fold higher for patients with a valve disease than without. Now, the risk of thromboembolism is higher for mitral valve compared to other valve replacements, and anticoagulation is essential in such cases. Now, as per the AHA/ACC guidelines for valvular heart disease, the first-line therapy for the mitral valve prosthesis is vitamin K antagonist therapy, e.g. warfarin plus aspirin. Now, the aspirin dose can range anything from 71 to 100 milligrams daily. Now, for mechanical valve replacement, warfarin therapy should be used regardless of the location, whether it's mitral or aortic. Now, aortic mechanical valve replacement requires warfarin therapy with a target INR range of 2 to 3, while the mitral valve mechanical replacement requires warfarin therapy with an INR target of between 2.5 and 3.5. So pay attention to those ranges. Let's move to the next question, please. Our next question reads, Mr. MJJ, a 74-year-old Kenyan male patient weighing 103 kilos, was recently diagnosed with PE at your hospital. Currently, he takes a fixed-dose combination of lisinopril and hydrochlorothiazide, 20/12.5, at a dose of 1 tablet daily in the morning. He takes 40 milligrams of atorvastatin at bedtime and 1 multivitamin tablet for supplementation. He admits having sporadic adherence to his current dosing regimens. His recent lab values include a WBC of 10.1 times 10 power 3, hematocrit of 46.4%, his HB stands at 16 grams per deciliter, the platelet count is 350,000 per microliter, sodium levels are 135, potassium is 4.2, chloride is 101, CO2 is 22 milliequivalents per liter, the BUN stands at 25, serum creatinine is 2.3, and the creatinine clearance is 42, some kidney issues there. So my question to you is, which of the chronic care treatments listed below would best suit Mr. MJJ? Would it be rivaroxaban 15 milligrams orally twice daily for 3 weeks, followed by 20 milligrams once daily? Or would it be enoxaparin 100 milligrams administered subcutaneously twice daily for 5 days, alongside 5 milligrams of warfarin once daily? Or would it be 60 milligrams of edoxaban taken orally once daily? Or would you settle for 100 milligrams of enoxaparin subcutaneously twice daily for 5 days plus rivaroxaban at a dose of 15 milligrams twice daily for 3 weeks? I will give you 10 seconds to choose the correct answer. So B is the correct answer. Enoxaparin is appropriately dosed for weight. Remember, he weighs 1 or 3 kilos, and it's also correct for indication, VTE treatment, to be precise. And it should be given with warfarin as bridging therapy for 5 days, or you can opt to give it until the INR reaches target. Now, edoxaban should be used in patients with creatinine clearance above 95, and if the creatinine clearance is between 15 and 50, the dose should be reduced from 60 to 30 milligrams orally once a day. So that dose would not be suitable for our patient or our case. Rivaroxaban doesn't require renal dose adjustment until a creatinine clearance value of below 15 ml per minute. However, due to this patient having issues with adherence, rivaroxaban may not be the most optimal choice for him, because there would be an increased risk of thromboembolic events if he prematurely discontinues his intake of rivaroxaban. Now, due to the rapid onset of rivaroxaban, it isn't necessary, in my opinion, to bridge therapy with enoxaparin for optimal treatment. Now, when initiating anticoagulation therapy, renal function, pharmacokinetic profile, and patient adherence should all be considered when determining the medication regimen. I would just like to add that direct oral anticoagulants, the DOACs, such as apixaban, edoxaban, and rivaroxaban, carry US boxed warning that states that premature discontinuation increases the risk of thromboembolic events. So patients that are not fully adherent are not good candidates. Could have an event. So you need to have that serious talk with them before you settle for a DOAC. Now, warfarin may be preferred in patients with adherence concerns due to its longer half-life. Missing one dose would not be as grave as missing a DOAC dose, for example. Just as a by the way. Let's move to the next question, please. Our next question reads, which of the drugs listed below causes antibody-mediated thrombocytopenia? Is it linezolid, vancomycin, danaparoid, or pantoprazole? I'll give you 10 seconds to choose the correct answer. So vancomycin it is. The most common causes of thrombocytopenia include the following: chemotherapeutic agents, heart failure, linezolid, low molecular weight heparin, quinine, ranitidine, ticlopidine, valproic acid, and vancomycin. Vancomycin is associated with thrombocytopenia in a small number of patients. It is also implicated in antibody-mediated effects similar to those of quinine-induced thrombocytopenia. It appears that some patients will develop antibodies specific to GP2B, 3A, on platelet surfaces. Now, the type of antibodies formed seem to be predominantly IgG antibodies, but they can also be a combination of IgM only or a combination of IgM and IgG antibodies. Now, as it relates to heparin causing thrombocytopenia, it's also important to know that unfractionated heparin is most likely to cause antibody-mediated hit than low molecular weight products. Ticlopidin is associated with TTP, thrombotic thrombocytopenia purpura, while we know that linezolid suppresses the bone marrow. That's the mechanism by which it causes thrombocytopenia. Just as a by the way, let's move to the next slide. And the question reads, Mrs. ALK, a 57-year-old female patient, presents to your hospital with a past medical history of coronary heart disease. She belongs to the New York Heart Association Class 3 with half ref. Now, her left ventricular ejection fraction is below 40%. She also has type 2 diabetes mellitus and is hypertensive. Today at the clinic, her chief complaint is palpitations, dizziness, shortness of breath, chest pain, which is unrelieved by sublingual nitroglycerin. A 12-lead EKG reveals atrial fibrillation with a heart rate of 115 beats per minute and a QTc of 430 milliseconds. Currently, she takes sublingual nitroglycerin at a dose of 0.4 milligrams administered sublingually PRN when she experiences chest pain. She also takes 20 milligrams of lisinopril orally once daily, 5 milligrams of warfarin, 40 milligrams of atorvastatin, that is a high-intensity statin therapy, at night. She also takes 100 milligrams of metformin orally twice daily, after breakfast and after dinner, alongside 5 milligrams of glipizide once daily. Some of her pertinent labs include a serum creatinine of 0.9 milligrams per deciliter, and her INR is 2.5. So my question to you is, which of the options listed below would be the most appropriate for Mrs. ALK's chronic management for her atrial fibrillation? Could it be 0.125 milligrams of digoxin administered orally once daily? Or would it be 180 milligrams of verapamil taken orally once a day? Or would you opt for AV needle ablation therapy with a pacemaker placement? Or would you settle for 12.5 milligrams of carvedilol taken twice daily? Or would you settle for 200 milligrams of amiodarone taken orally once a day? I'll give you 10 seconds to choose the correct answer. I would settle for 12.5 milligrams of carvedilol taken orally twice daily. Now, in my opinion, rate control is the preferred initial treatment goal versus rhythm control. Now, using a beta blocker or a non-dihydropyridine calcium channel blocker is the recommended means of rate control for patients with paroxysmal or persistent or permanent atrial fibrillation. Now, since this lady ALK has left ventricular dysfunction with an LV ejection fraction of below 40%, a non-dihydropyridine calcium channel blocker should not be used due to possible hemodynamic compromise. There will be problems. Now, AV nodal ablation is indicated for patients when pharmacologic therapy is inadequate and rhythm control isn't achievable. So C is wrong. Oral amiodarone is a reasonable rate control option when other agents have been unsuccessful or are contraindicated. So E becomes wrong. And then digoxin, in my opinion, isn't a preferred first-line agent, but it may be combined with a beta blocker or a non-dihydropyridine calcium channel blocker for improvement of ventricular rate control during exercise or in heart failure, since it doesn't have negative inotropic effects. So I would settle for D, carvedilol 12 milligrams twice daily orally. Let's move to the next slide, please. HPB. A 67-year-old male patient presents to your anticoagulation clinic with non-valvular atrial fibrillation. He has a past medical history of coronary artery disease, hypertension, type 2 diabetes mellitus, and congestive heart failure. His renal and liver functions are within normal limits. He weighs 75 kilos and currently takes 20 milligrams of rivaroxaban every evening with his dinner. And at his recent cardiology visit, his provider stated that he may require a PCI for the management of his coronary artery disease. He inquires how this would impact his anticoagulation therapy. So my question to you is, based on the Pioneer AF trial, which of the management strategies listed below would best suit Mr. HPB the most? Would it be 15 milligrams of rivaroxaban taken orally once daily, together with 75 milligrams of clopidogrel once a day? Or would you settle for a case where you stop the rivaroxaban and initiate warfarin and titrate it to an INR goal of 2 to 3 alongside 81 milligrams of aspirin orally once a day and 75 milligrams of clopidogrel once daily, all orally? Or would you settle for 81 milligrams of aspirin once a day and clopidogrel at a dose of 75 milligrams orally once daily? Or would you opt for 20 milligrams of rivaroxaban once daily, co-administered with 81 milligrams of aspirin once daily? I will give you 10 seconds to choose the correct answer. I would opt to give 15 milligrams of rivaroxaban once daily alongside 75 milligrams of clopidogrel once a day. Now, based on the Pioneer AF trial, patients who received rivaroxaban 15 milligrams orally once daily or 10 milligrams orally once daily, if their creatinine clearance was between 30 and 50, plus 75 milligrams of clopidogrel for a year, had lower clinically significant bleeding compared to patients who received standard care of adjusted dose warfarin to the INR range of 2 to 3 alongside aspirin 81 milligrams orally once daily and clopidogrel 75 milligrams orally once a day. And this makes answer A correct and B incorrect. Now, it isn't necessary to stop rivaroxaban therapy after PCI. This was not recommended by the Pioneer AF trial at all. In my opinion, triple therapy may only be needed for the highest thrombotic risk patients following a PCI procedure due to increased risk of bleeding if you use the three together. Now, aspirin plus clopidogrel alone wouldn't be a correct choice because discontinuing anticoagulation would increase the patient's risk of stroke because he has a non-valvular atrial fibrillation. He will still require anticoagulation for his AFib. And the antiplatelet agents, that is aspirin and clopidogrel, for his coronary artery disease status post a PCI. Now, the option of rivaroxaban plus aspirin wasn't a subgroup studied in the Pioneer AF trial, and there isn't enough supporting evidence to support the use of this regimen immediately after PCI. So I wouldn't opt for that one. Then compared to clopidogrel, the third generation P2Y12 platelet inhibitors such as ticagrelor and prasugrel result in a greater degree of platelet inhibition and are associated with increased non-cabbage related bleeding. Therefore, clopidogrel is preferred to the other P2Y12 platelet inhibitors, that is ticagrelor and prasugrel, in such circumstances as this one that we are faced with. Let's move to the next question, please. Mr. CGM, a 69-year-old male patient, presents to the clinic with permanent atrial fibrillation. He is currently on rivaroxaban. He presents today with symptoms of heart failure decompensation, possibly a sign of pulmonary embolism and pericardial effusion. The cardiologist would like to perform a pericardiocentesis, but prefers to wait until the rivaroxaban has been weaned off. So my question to you is, which of the lab tests listed below would best be used to assess the rivaroxaban levels? Would it be hemoglobin? Would it be APTT? Would it be anti-factor 10A levels? Or would it be the patient's INR? I'll give you 10 seconds to choose the correct answer. Anti-factor 10A levels it would be. Now, rivaroxaban is a factor 10A inhibitor. Therefore, an anti-factor 10A level is the most appropriate. I would like to remind you that PT and APTT may also be used to reliably measure rivaroxaban activity. However, it is accepted that the anti-factor 10A level is a more specific test for rivaroxaban. It is rare to find anti-factor 10A activity in untreated patients, but several medical conditions may influence the PT level, making it rather non-specific in my opinion. The INR, on the other hand, is a test that has been standardized for patients being treated with vitamin K antagonists such as warfarin. The mechanism of action of warfarin differs from that of rivaroxaban. Therefore, INR, in my opinion, wouldn't be the appropriate test for rivaroxaban levels. That makes answers A, B, and D incorrect. Let's move to the next slide, please. And the question reads, Mr. POZ, a 55-year-old male patient, presents to the anticoagulation clinic and seeks clarification about reversal agents for direct oral anticoagulants, the DOACs, specifically andexanet alpha. So my question to you is, which of the statements below is incorrect in relation to andexanet alpha? Is it andexanet alpha should be used for reversal of life-threatening bleeding? Or is it B, andexanet alpha is approved for the reversal of dabigatran, apixaban, and rivaroxaban? Or is it, if andexanet alpha isn't available, there are other ways to stop bleeding with DOACs? Or is it, in case of DOAC overdose without bleeding, use of reversal agents is typically not recommended? I'll give you 10 seconds to ponder and choose the correct answer. B is the correct answer, because it is an incorrect statement. Now, idarucizumab is approved by the FDA for the reversal of dabigatran, and andexanet alpha is approved only for the reversal of factor 10A inhibitors such as apixaban and rivaroxaban, never for dabigatran. Now, based on expert guidance from the Anticoagulation Forum, reversal agents should be used for major bleeding if it is life-threatening or if it can't be controlled with supportive measures. Now, if andexanet alpha isn't available, supportive measures can be taken to reverse the bleeding. 4-factor prothrombin complex, what we abbreviate as PCC, can be used for reversal of apixaban and rivaroxaban. Now, considering the uncertain risk of bleeding due to overdose, the short half-life of the DOACs, the cost and potential of using these reversal agents, there is a lack of evidence supporting their use during overdose without evidence of bleeding, so I would not use them. The benefits would not outweigh the risks in this particular case. Now, dosing andexanet is based on the specific DOAC administered, the dose administered, and even the time that has elapsed since this DOAC was administered. So those are things you should pay attention to when using andexanet alpha to reverse either apixaban or rivaroxaban. Just as a by the way. Let's move to the next slide, please. And the question reads, Mrs. J.A.W., a 58-year-old female patient, presents to your anticoagulation clinic with complaints of fatigue, weight gain, and sensitivity to cold. She has a past medical history of hypertension, atrial fibrillation, and GAD. She is stable and appears adherent on medication. She currently takes a fixed-dose combination of lisinopril co-formulated with hydrochlorothiazide, amiodarone, rivaroxaban, metoprolol, and pantoprazole. Her labs reveal hypothyroidism, and her physician decides to add levothyroxine at a dose of 12.5 micrograms orally once daily to her regimen. So my question to you is, which of the drugs listed below from her regimen could cause drug-induced hypothyroidism? Is it the fixed-dose combination of lisinopril and hydrochlorothiazide? Is it amiodarone, metoprolol, or rivaroxaban? I'll give you 10 seconds to choose the correct answer. amiodarone it is. Now I would like to remind you that every 200 milligram tablet of amiodarone contains 75 milligrams of organic iodine, and that provides more than 100 times the daily iodine requirement in a normal adult. And it has some structural similarities to the thyroid hormone. It can either lead to hyper or hypothyroidism. Now, due to what we call the Wolff-Chaikoff effect, the thyroid gland typically adapts to the iodine overload provided by the amiodarone that is taken in AFib and other arrhythmias by inhibiting iodine organification and by reducing the rate of the thyroid hormone production, which leads to an increase in serum TSH. Now, hypothyroidism develops due to the inability of the thyroid to escape, in quotes, the Wolff-Chaikoff effect. Now, hyperthyroidism can result from amiodarone causing subacute destructive thyroiditis with consequent leakage of formed thyroid hormones into the circulation, or from the utilization of excessive iodine being used to accelerate thyroid hormone synthesis. Now, just like to underscore the fact that the other drugs, lisinopril co-formulated with hydrochlorothiazide, metoprolol, and rivaroxaban, do not show any profound effect on the thyroid gland or its hormones at all. So, my highly esteemed viewers and listeners, that brings us to the end of part 43 of our pharmacotherapy MCQ series. If this video benefited you in any way, I would like to urge you to please remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come. Thank you very much for viewing and for listening to me. I sincerely appreciate your partnership and your continued support and your kind collaboration. I look forward to interacting with you in the next video in part 44 of our pharmacotherapy MCQ series. Thank you very much.